Can you all hear me okay?
Yep, I can hear you.
Perfect. Hang on. As you all know, the goal of this brief presentation is just to keep you all up to date about some changes that are hopefully being implemented within the ICU within the next month and a half. As many of you are familiar with intubation, you may identify that the main difference between intubation that is performed in the medical intensive care unit by our intensivists versus the intubations that are performed when we call our anesthesia colleagues or those that are working in the emergency department is often the difference between the use of paralytics. We know with rapid sequence induction, the steps are the same for RSI versus the standard intubation that we do alone. You're preparing your patient for intubation, ensuring that they have appropriate pre-oxygenation, that they receive pre-treatment with your etomidate or other sedative choice. The main difference between rapid sequence induction for intubation is that it involves paralysis with induction. You're going to continue your other P's of intubation, which include positioning, proof of placement, and your appropriate post-intubation management. The reason that we're working to implement rapid sequence induction and intubation is primarily to minimize the chance of pulmonary aspiration. When we're working to intubate patients, our goal is always to intubate them as quickly as possible to eliminate any prolonged hypoxia. But this also allows us to protect the airway quickly and reduces any chance of passive or active regurgitation because our patient, when they're paralyzed, are unable to cough, strain, or have any emesis enter the airway as it's being manipulated. There are some agents for rapid sequence induction, and many of these will be agents that you're familiar with, and then some less so. Pre-treatment, you can continue to use fentanyl for rapid sequence intubation or rapid sequence induction, and then you're also going to choose similar sedatives. So we'll likely continue to use etomidate or Versed. Most often etomidate is going to be the medication that you're choosing. There might be an occasional patient where you choose an alternative like ketamine or Versed, and then you'll have a choice of one of two paralytics, succinylcholine or rocuronium. Rocuronium has a reversal agent called Sugamidex. And so when we're talking with pharmacy, the plan will be to store rocuronium as well as Sugamidex within the medical intensive care unit so they can be available, both your paralytic as well as the reversal agent for your paralytic. So I would advise you as you're growing in your fellowship, just to become familiar with these medications, succinylcholine and rocuronium, the indications for these medications, as well as how to dose them. I'm going to have a specific lecture that is available. I'm going to host it on WebEx, and then will be available for more in-depth education on these specific paralytics. But as you're working, on yourself in development as a physician, just become familiar with these two paralytics of choice as they're the common paralytics used in rapid sequence induction. The bedside needs that you'll have for rapid sequence induction are going to be the same as those you would need for your standard intubation. So this really doesn't change in any way. Your yellow airway box is the airway box that you're going to bring to the bedside, including your backup or failed airway equipment. So if your choice is to do direct laryngoscopy and your normal backup is GlideScope or bougie assist, then make sure those things are there. Your monitoring systems are going to be the same, particularly the blood pressure cuff or art line that you have present in the medical ICU, as well as your medications, IV line, and your end-tidal capnography. Again, the only major difference between rapid sequence induction and the way that we're currently doing intubation is the use of paralytic. From a kind of, what's the appropriate term? just from a standpoint of requirements from providers, we know that our faculty are all credentialed in intubation. What you're going to see over the course of the next couple weeks and months is that we'll have a course offered for a rapid sequence induction refresher, just because since we haven't had these medicines routinely being used, there are some people who may just be out of practice with familiarity of the use. The way that anesthesia requires administration is that the faculty would be administering the paralytic through the IV, and the fellow that's performing the rapid sequence induction will be supervised by the faculty who's administering the paralytic. And that allows us to comply with the protocols they have for deep sedation outside of the operating room. There are nursing requirements, which you have to be less familiar with, but your nurses will have familiarity with ACLS certification. They all have undergone education for appropriate monitoring during sedation and intubation, and they will also become familiar with these medications as nursing is undergoing the same educational efforts that we have for our physicians. From a pharmacy standpoint, we have these two paralytics available, both succinylcholine and rocuronium available. What we're working to ensure is in the Pyxis is rocuronium. And the reason is there are fewer contraindications to rocuronium than succinylcholine. And so if we're picking one, the one with fewer contraindications is the one that we're choosing to be or to have present within the Pyxis. And as we go throughout our learning on succinylcholine and rocuronium in the future, you'll begin to learn what the contraindications are, and perhaps when to actually call for succinylcholine instead of rocuronium, because there may be times where that is your choice. As far as what this would look like in real life, we can start at the top of the screen here. If you identify a patient has a need for rapid sequence intubation, you're going to gather your supplies for your medical intubations in the same way that you would do currently. Your airway supplies and adjuncts will be reviewed by you, the intubating physician, and then the nurse will obtain the sedation medications and paralytics from the patient. Because our deep sedation policy is ideally done with two physicians, you would have a two-physician team with the attending administering the paralytic and the fellow intubating. And then if there was a situation where there's a single physician intubation, and this would mean just an attending alone, because we don't want our fellows using paralytics without supervision. If there's a single physician that's doing this, meaning your upstairs night intensivist, then the nurse would be administering the paralytic. Once your RSI is initiated, then hopefully we all move to this upper right orange oval with a successful intubation. However, if there's a failed intubation or a need for paralytic reversal, you have the opportunity to use Sigamidex from the Pyxis. Most oftentimes, if your airway is failing for a lack of successful intubation, paralytic reversal may not be the reason. Sometimes paralytic reversal is not the next choice, but rather, you're having you're doing this as you're calling your urgent airway team or the other physicians that are part and parcel to establishing a successful airway for your patient. What's going to be important for you as fellows or whoever is doing these procedures is going to be documentation. One of the caveats to our documentation for intubation is to make sure that we do pre-sedation or analgesia evaluation. And this is something that is present in your procedure notes, but not everybody is doing. So please make sure when you're doing your intubation that this is something that you evaluate. Number one, what is your patient's pre-sedation ASA class? Most of our patients are 3 or 4. I mean, rarely will we have an ASA class 1 that we're intubating, unless this is just an elective intubation for somebody who's, I don't know, maybe has a drug overdose or something like that. But for the most part, we're going to be 3, 4, 5, or emergency. And then your pre-sedation Mallampati score, this is something that you should be evaluating on all of your patients. And if you put this pre-sedation ASA score or Mallampati score in, prior to, for your central line or for your art line on Tuesday and you intubate them on Friday, these will still be present. So I would recommend that you update them if your patient's clinical condition changes. If it's the same, your Mallampati score shouldn't change unless your patient has lead wigs or some other terrible oral airway obstruction. And in that case, you're probably not going to be doing the intubation alone at bedside. But if you are, please make sure that you document this, because this will help us comply with the requirements that anesthesia has set forth. It's important that we have appropriate nursing documentation, but it's already accomplished by our nursing via the code summary. And so that won't be an issue that you'll have to be conscientious of. Lastly, there's airway assessment, or lastly, the important thing is, to write a note about your procedure. The airway assessment that you clicked off in regards to your ASA and Mallampati will self-populate here if you have done it. If not, it won't show up, and that means that your intubation note is not complete. Below that will just be what's consistent with your intubation note, which you guys already do consistently. So I just wanted to specifically bring up some of these logistical condition or considerations here today in these moments, and let you know to look forward to some more formal education on rapid sequence induction and the medications that we'll be using for RSI. If there's any specific questions or concerns, I'd be happy to take them. No questions, no concerns. It sounds like everybody's very excited. All right, well, you all have my email address and phone number. Most of you know where my office is. So if there's anything that comes up, feel free, or any questions or concerns that you had as we're working to roll this out, please let me know. I'm available in any way that you want to get in touch with me. Have a great day.
guys should unmute. Can everyone hear us now? Try now, I think.
We have it, yes. All right, sorry about that. Back to our talk on hyperkalemia and different physio or pathophysiological states that affect that. Tonicity is a huge one. We see this a lot in the ICU, especially in patients with hypernatremic, actually. So what happens when you're hypernatremic? You have increase in plasma tonicity. Water leaves from your cells to your ECF space. Then your concentration of your potassium inside the cells gets relatively high because you have your water leaving. Concentration is whatever the solute is over divided by water. And because of that, you have your efflux of potassium by your potassium permeable membranes. So tonicity itself can affect it from that standpoint. Next is acidosis. We're all pretty aware of this, but I just want to make a key distinction between normal anion gap, which is your hyperchloremic acidosis, and your high anion gap metabolic acidosis. And the main difference has to do with this complicated pathway, or complicated, not complicated. And you see more of a shifting of acidosis causing hyperkalemia from hyperchloremic or non-anion gap metabolic acidosis because of the fact that you have, it all has to do with this. Ultimately, you're decreasing your intracellular sodium concentration, therefore decreasing the activity of your sodium potassium ATPase. And this is a mechanism of how it happens. I have a pretty nice schematic in my later slides to show this. Whereas in organic or anion gap metabolic acidosis, such as ketones, for example, you have your intracellular movement of these organic anions with hydrogen ion, again, to maintain electron neutrality. You have a decrease in your intracellular pH, therefore, you have an influx into the cells of sodium, maintaining this sodium concentration inside the cells. Therefore, your sodium potassium ATPase activity is relatively preserved. Okay. This is what I essentially just talked about. The key distinction is over here. You have your influx of organic anions with hydrogen or proton, causing this a decrease in cellular pH, right? With a sodium hydrogen exchanger maintaining an intracellular sodium concentration. Therefore, this guy over here, the activity is preserved. Hence, this is why you have more, or we see more of a hyperkalemia from non-anion gap metabolic acidosis versus anion gap metabolic acidosis. Okay. What about respiratory acidosis? Respiratory acidosis, again, for the sake of time, we'll just kind of briefly go through this, but you can think of it as similar to organic acidosis, metabolic acidosis, similar to how, say, for example, you have ketosis going on, whereas you're preserving your intracellular sodium concentration. Therefore, there's less inhibition of your sodium potassium ATPase and reduced extracellular shift. Okay. Also, another mechanism is that with a increase in PCO2 concentration, that the CO2 is going to go into the cells, thereby lowering your intracellular pH over here, increasing the activity of your sodium hydrogen exchanger, this guy over here, with a preservation of your intracellular sodium concentration, hence a less of an effect from this. It's a diagram showing where potassium homeostasis happens in different parts of the kidneys and the tubules. Okay. All right. So renal handling of potassium. Decreased renal potassium excretion, mainly, I would say, I just categorize it as these three predominant mechanisms. A major one over here is distal luminal sodium delivery. When that goes down, that's when you run into issues, and we'll see why later. Mineralocorticoid aldosterone deficiency or lack of response, or an abnormal cortical collecting tubular function. Okay, so potassium is being excreted via in the distal nephron, and aldosterone is huge in regulating this. And it all depends on a transepithelial voltage gradient between your urine side and your plasma side. Okay, urine side is if you keep the lumen on the urine side negative or electronegative, your potassium will is drawn towards that. And how do we maintain, how do the kidneys maintain that? It's by the ENaCs, in reabsorption of your sodium in the distal nephrons. Therefore, distal lumen delivery of sodium is actually key. Again, busy diagram, but this is essentially the mechanism over here. Let us focus on right here. Think of this as your distal tubules right here. Your sodium is going to go through this ENaC channel, right, making this side more electronegative. Hence, your potassium through the ROMK and your other potassium permeable channels going to get drawn towards that in getting rid of potassium in the urine. Again, this is similar to this blown up ENaC channel. Sodium goes in, sodium potassium ADPase, because there's an electrical gradient, potassium goes out. Right. Having said that, we can kind of see why AKI and CKD, how it differs in potassium homeostasis. Really, if someone's EGFR is greater than 15 to 20, it's somewhat uncommon to have moderate or severe hyperkalemia. Compare that to AKI. In AKI, it's more commonly seen in oliguric or anuric states because of this decreased distal tubular delivery of your sodium, as we just described before. So when someone has an AKI, they're not really oliguric. Life-threatening hyperkalemia is pretty rare. Okay, of course you got to think about all these other conditions that generates potassium, and that's when sometimes in a lot of our patients this balance gets messed up. All right, so let's go on to the next case. We have a 34-year-old female with HIV/AIDS in the MICU, acute respiratory failure, X-ray with bilateral infiltrates, started on pentamidine due to PJP pneumonia. I heard a snap of a finger somewhere. Anyways, labs and admission, sodium is that, potassium is okay. CPK is 1100. Day 3, sodium is 139, potassium is 6.5, chloride is 111, bicarb is 17, creatinine bumped up to 1.5. Urine output has been maintaining. What is the cause of this patient's hyperkalemia? And we have our 4 choices from above. So I'll just go back to this question stem for everyone to reread it. And 2. Okay. No. Sorry. Did you say drugs? Everyone. Okay. It is. Yeah. All right. Right. In talking about drugs, we gotta come to the RAAS system. Very busy slide, but I just want to kind of point out how in this complicated RAAS system, how in different areas, very commonly used medications impair or affect the system in different at different pathways or different spots, I should say. Pentamidine is right here. It's similar to a commonly used potassium-sparing diuretic, amiloride, that we use, in that it blocks your ENaC channels over here. And like we explained before, if you don't have this sodium influx distally, you don't have that big gradient, electrical gradient, therefore your potassium will not come out, okay? ACE inhibitors, ARBs, we're pretty familiar with. Heparin is another one, okay? how heparin causes hyperkalemia is it kind of impairs aldosterone metabolism. So no aldosterone, potassium cannot get out. So heparin is a huge one. I just listed kind of all the drugs where it acts and all that stuff. So again, heparin, ketoconazole, we're pretty familiar with ARBs, spironolactone, inhibition of renin release, CNIs, calcineurin inhibitors, tacrol is a huge one. Don't forget about this, and of course, pentamidine, the ENACs. All right. Coming on to the next case, we have a 52-year-old male with CLL coming in here with worsening fatigue. Blood pressure is relatively okay. It's tachycardic. Respiratory rate is 22, statin 91% repair. Labs CLL. White count is 120,000. Hemoglobin is 3.5. Platelet is low too. And sodium is 128. Potassium is 7.5 with no mention hemolysis. You have your bicarb there. Uric acid is 4.5. Phos is 3.8. And X-ray expected, EKG with no evidence of QRS abnormalities or peak T waves. So how will we manage this patient's hyperkalemia at this point? Sorry, here are the choices. You can try to do 1, stabilize the cardiac membrane, shift 2, sodium zirconium, which is Ocalma, constant nephral to dialytes, repeat with whole blood potassium. And back to STEM. I will say that again. Whole blood. Very good. Yeah. Yeah. Right. Yeah. Well, let's talk about pseudohyperkalemia. Commonly, this is well known. You know, you put a tourniquet for too long. You join someone's blood. This doesn't happen in ICU, but outpatient setting, they're like clenching their fists and whatnot. Alcohol is a huge one. You wipe their skin with alcohol. You don't let it dry, so that can cause hemolysis. But leukocytosis, especially in the setting of very high leukocytosis, such as in blood cancers, hematologic malignancies, is a huge one. And the reason is, and to talk about that, we got to talk about the difference between whole blood red blood cells, whole blood plasma serum, right? So whole blood is whole blood. When you draw it, there's anticoagulant in there. Plasma, what happens is that you draw the same tube, still got anticoagulant in that. Then you put this in the centrifuge, and that's how you get the separation. Okay. Serum is essentially, there is no anticoagulant in the tube. You draw the blood, you let it clot by itself, and that's how you get a serum. Okay. So having said this, what can contribute to a pseudo-hyperkalemia in this case is that because this patient has very high leukocytosis, they're very fragile, likely blast cells. When you put them in a centrifuge, that can actually release, causing cell lysis, releasing potassium in there. Okay, therefore, get a whole blood, keep it cool, run it down, and recheck it. All right. Assess renal response. I think kind of like FENA, you have your FECA, I guess, FEC. It's similarly calculated like a FENA to assess proper renal response. Management, I think we're pretty good with management. Obviously, assess the urgency first. Assess the patient as a whole, see if there's a condition where there's a rapid rise in potassium, where you're expecting a rapid rise, such as very bad rhabdomyolysis. And if the patient is non-oliguric and hypervolemic, we can try some diuretics. And again, we can try to give some bicarb in patients who are hypovolemic, where they need the additional volume with metabolic acidosis. I do just want to point out that we got to be cautious with bicarb pushes. Does anyone know why? in trying to get this, in trying to correct hyperkalemia with metabolic acidosis, why we want to avoid bicarb pushes. Because of this, tonicity, right? Right. So, right, bicarb pushes are super hypertonic, and then you get this phenomenon going on. Then you're back to square one. That's key thing. Another thing I did want to point out is, oh, that's right, calcium salts. Calcium salts, when we give calcium, it synergizes a digitalis action and activity. So in someone who's hyperkalemic with high levels of digoxin, they are on digoxin, the levels are high, or you're suspecting toxicity actually, be very worried about that. EKG changes or hyperkalemia, pretty familiar with. Right here, categorization somewhat. Again, it's someone whose pace obviously is a little hard. Only so these guys studied 90 patients with K of over 6. Only truly 18% had these classic EKG changes that we're all taught. And of course, potassium concentration is an independent predictor of mortality. Okay. So the ER, typically we see someone with hyperkalemia, we give insulin, dextrose, all that good stuff. So insulin kind of drops your potassium within 10 to 20 minutes, pretty reliably by about 1 milliequivalent per liter. And beta agonists have an additive effect and typically onset within half an hour to an hour. So doing these two management alone, these guys actually published a paper back in 2001, and they looked at a whole bunch of patients, actually ESRD patients, just by doing these measures. In the absence of high generation, again, you don't have someone whose cells are dying on you, their leg is dying. In the absence of high potassium generation, these measures are pretty effective in getting potassium down less than 6.5 within 1 to 1.5 hours. So this is back in 2000. These guys back in 2000 published a paper in a journal of accident and emergency medicine showing the effects of insulin with glucose, and here a beta agonist with the added effects of insulin. And you can kind of see a mean, where is it? Or a peak reduction in potassium shown here and here. So pretty good. You can, by doing these two measures alone, we can kind of drop the potassium by greater than 1 milliequivalent per liter. Of course, by doing that, you're essentially trying to get the potassium back in the cells, but you're not really getting rid of it from your total body stores. That's why we have medications that we currently use to promote interlosses. We don't use this guy over here too much anymore because of, as we all know, colonic necrosis and all the bad effects from that. This we mainly use here. And I'll just, in the next couple slides, I'll just briefly go over some of the studies showing the efficacy and the safety of this guy over here. Oh, some case reports of sodium polystyrene oxalate causing intestinal necrosis and that stuff. This one was back in 2018. This one is 2020. Right, so these guys actually did a systematic review in 2013 and found 30 reports showcasing 58 cases, 44 of which involved colonic involvement, and 36 cases had transmural necrosis, which led to this the black box warning. Okay, so this was back in 2000 when this medication first came out. It's funded by the pharmaceutical company that made this. So what these guys, the study was kind of, the method for the study was in two phases. One was the initial phase and one was a maintenance phase. We'll just look at the initial phase. The green over here is your placebo, and you have your different doses of lokelma, essentially, looking at how it affects potassium in 48 hours. You can kind of see that by 48 hours, there's a statistically significant drop in your potassium concentration or level. This was from, so these authors did the harmonized trial, which was a retrospective, randomly controlled trial looking at the effect of lokelma 10 gram TID in outpatients with mild hyperkalemia, mainly as a maintenance therapy. But later on, when they published this correspondence in New England Journal of Medicine, what they did was that they did a retrospective reanalysis from that study focusing on 41 patients whose initial potassium was over 6 and who received 10 grams of lokelma, looking at the short-term changes within the first 4 hours. You'll see that on the graph over here. After this initial, after just one initial 10 gram dose. So the mean baseline was about 6.2. The mean level is 6.3. After one dose of the 10 grams castellate, dropped by 0.4 at 1 hour, and 0.6 at 2 hours, and 0.7 at 4 hours. Again, only 41 patients. The initial study was mainly in the outpatient setting. Again, no mention of symptoms, signs of clinical derangement, nothing like that. So definitely take it with a grain of salt. This was a study published in the Energize, published in emergency medicine journal, where it looks at the efficacy of lokelma in addition to insulin glucose as a treatment of hyperkalemia in the emergency room. So these guys randomized in two groups. One group is just insulin plus dextrose. The other one is insulin, dextrose plus lokelma. It was a multi-center randomized, double-blind, placebo-controlled, and they put a patient with potassium of 5.8, one-to-one randomization, and looking at the outcomes. Key exclusions include, of course, patients with pseudohyperkalemia, life-threatening arrhythmias, or they expect to get dialyzed within 4 hours, or any condition whereby treating the underlying cause is a better treatment option than just insulin and dextrose alone. And what these guys found was, so let's focus on this graph on the right. There is a trend towards patients treated with lokelma along with insulin and dextrose achieving potassium less than 6 and requiring less further treatments for hyperkalemia. Again, relatively small study, and I will also take it with a grain of salt because these patients received other treatments along in their course that could affect the potassium itself, including fluids, diuretics, and all that stuff. We have an 80-year-old obese male with hypertension with cardiogenic shock complicated by cardiac arrest few hours, placed on ECMO, VA ECMO. Within 24 hours of cannulation, hyperkalemia of 8.5. He's anuric. He was given medications, temporizing medications several times. So what do you do in this case? CVVH with a 2K replacement fluid, okay. Any takers for sleds? or localma? Maybe SLED, okay. I'm not looking at you. Okay, okay. So essentially the first two choices are CRT. Third, we can eliminate localma. What about fourth with intermittent hemodialysis? Then CVH. Right, yeah, okay. So what, you're absolutely right, he is on VA ECMO. However, the correct answer in this case, as Stan already knows, it is intermittent hemodialysis for 4 hours, okay, with a 2K bath, then CVH. And the reason why is, well, I think I have some data, concrete data. Right, exactly. It's way too inefficient for CRT to rapidly bring down potassium level in the setting of this obese man who is on VA ECMO, a circuit that can hemolyze, right, with a life-threatening hyperkalemia at this point, who's also anaemic. So renal replacement therapy in hyperkalemia, obviously we do it. Options are CRT versus conventional intermittent. So conventional is highly efficient in rapid removal of potassium. Again, it depends on prescription, which includes a time, how long it's run, blood flow, dialysate flow, what potassium bath you're using, and your body size, of course. Again, remember when we're dialyzing someone, we're dialyzing their plasma, not their whole body, right? You can't put a catheter inside cells and take that out. So you're going to have a rebound after you stop this from intracellular to extracellular shift of your solutes. So this was taken from Annals of Intensive Care back in 2019. This is essentially looking at IHD, essentially intermittent hemodialysis for 4 hours. We can think of clearance and dialysate very similar. On the x-axis, you have your potassium bath, essentially what we're running with. This is your urea clearance, what we typically measure efficiency of dialysis is. Remember, there is no urea in the dialysate bath, so it's going to be a constant. So we use this as to compare it to dialysis sense of potassium. When we have a 0K potassium bath, which we don't use here, our lowest goes to 2, it obviously equals that clearance of urea because they're both very small molecules, highly efficient taking it out. You can see that in milliliters per minute, it's quite high. Okay, this is your flux of potassium, again, by different baths, right? And this is what your plasma of potassium will do with an IHD session. Now compare this, remember the units here, to say, for example, a CVVH that lasts for 24 hours, okay? Milliliters per minute, milliliters per minute. On the x-axis here, 24 hours versus 4 hours. Okay. This is a good graphical, I guess, comparison of CRT modalities to IHD, which is why in someone with life-threatening hyperkalemia with high solute generation, we want to get it down quickly with intermittent. Then as a maintenance therapy, we can consider CRT. Humor. All right, almost running out of time. We'll quickly go over hypokalemia. Again, hypokalemia can happen with intracellular shifts. Obviously, you can lose it from your kidneys or your GI tract. Okay, so we have a 40-year-old female in emergency ICU. Sounds similar, kind of familiar to a previous case we just did with diagnosis of AML, EKG, no significant abnormalities. You have your labs here, potassium is 2.6, creatinine 0.84, it's fine. White count is 300,000 with very high percentage of blasts. Hemoglobin and platelets are pretty low. So what is the next best step? Check mag. Reasonable. Any other takers? I'll just ignore this.
Yeah. Slightly a track.
It's actually none of the above here. So,
A lot of like, let's say,
right.
they do pseudo-hyper or pseudo-hypo. They do both.
If you don't lyse, right, those really active cells can uptake potassium if you don't lyse. Yeah. Not a common, but it still happens. So be aware of this. How do you tell? You again put it in the whole blood, cool it, right, and send it out. We'll ignore this. So this is kind of an algorithm, if you will, of sort of a workup for hypokalemia. Okay, we want to mainly assess renal potassium handling, and which will separate your kind of mainly we're interested in this part over here, which is the kidneys are dumping potassium inappropriately. And why is it dumping? We can kind of look at their hemodynamic status. Are they volume up, normal, low? Most of the cases in ICU, we kind of go towards this route, and then we look at a bicarb. Hypokalemia, right, usually associated with alkalosis. So this kind of narrows it down to these two categories. And this I would kind of history and physical will help you out a lot. So next case, 30-year-old female with history of migraines come to the ER with intractable headaches with photophobia. She's in a migraine attack, looks like. Has been suffering from migraines for many years, states that she has been taking ibuprofen on a regular basis for the past few months. No diarrhea, no laxative use. Blood pressure is fine, pulse is 85, sodium 137, potassium is 1.8, bicarb is 15, MEG is fine, beer and creatinines are normal. Since you're in the ER, everyone checks the UA in the ER, pH is 6.5, okay, and that's your ABG to confirm that she indeed does have metabolic acidosis. So hypokalemia, what do we do? And I'm sorry, in this case is what is the most likely cause? Is she taking a diuretic? Is this an RTA? Does she have Cushing's or hyperaldo? Back to the stuff. And just to help you guys out, this is the kind of the algorithm. So her blood pressure is fine. She's not tachycardic. We will kind of go down this pathway, right? However, like I mentioned before, hypokalemia with an metabolic acidosis, a little odd, because you typically don't see that, right? So that kind of narrows it down to these two guys over here. So this is indeed an RTA caused by NSAID use, all right? One thing when we manage hypokalemia is to remember that the value we see is from the plasma, and that reflects a significant total body deficit. In the, say someone has potassium 3, for example, their total body deficit is upwards of 200 plus. So keep that in mind when we are trying to treat hypokalemia and trying to replenish that. How do you treat it? Intral if possible. You use the gut if possible. Of course, it's not always possible in our cases. And in someone with no renal dysfunction, there's very low risk of getting iatrogenic hyperkalemia if you use the gut. And tablet form, remember, it can cause some irritation of the gastric mucosa. You definitely use IV if they're having EKG changes or they're symptomatic, if they're not moving their limbs, if they're in paralysis from severe hypokalemia, definitely treat that. And these are your formulations for your oral. For someone who's also acidotic, these two are somewhat good options. For someone with concomitant hypophosphatemia, remember you have your option KPhos. And don't forget to treat the hypomagnesemia. And that's my talk. Right on time. All right. Any questions?
Someone that's hyperchloremic don't get on